Mr. Chairperson, Mr. Co-Chairperson, my friends, Dr. Bhave, Dr. Deshpande, Dr. Chogle, emotional time for me, 20 साल बाद, the IPS journey has been since 80s. I remember when I presented my first paper, and ever since I have, we grow in this association, and we see each other, our friends, mentors, teachers, researchers, educators. And when I finish this talk, I will again come back to IPS, how important it is to kindle resilience amongst members and make a difference to personal life. But thank you, Nikhil and Dr. Save, for giving me this wonderful opportunity. It's a homecoming to share my thoughts. Now, the topic is very innovative, very common. Often we discuss this. There are two ways I can handle this. One, that I will tell my friends like Avinash that let's write a review paper and dig out the data and structure methodologically what are the challenges and what are the opportunities. But I don't want to do that. Rather, I'm going to touch upon some soft and some very hard areas of our life and conclude with some fundamental suggestions that I feel is important. Caution certain important and pertinent risks that one must be careful about, and then leave it open for members to ponder it over. So let's examine the facts and find some answers. And my first thought is, by generation next and the nature of practice, do we mean by going the Western way? If that is the case, then it's a matter of big concern. What are the facts? The fact is that health itself is a major issue, not only of patients that you treat, but professionals' health themselves is a challenge. The second parameter I have taken is the level of happiness, and psychiatrists have done well across all over the world. Their level of happiness and contentment with practice has been rather amazing, 80, 85, 70% in different areas on this world. But let us also look around in our own community. India, United States, Canada, UK. Everybody knows that litigation against psychiatrists is rising. Income is becoming an issue. People don't talk about it very openly in meetings, but the fact is that shelf life of a clinical psychiatrist, even in institutions, even in private practice, is shrinking. It's not that you started your practice and you maintained it for 30 years. I hope it happens, but the young doctors to come will have to think and restructure the whole design. Stress, mental health issues, suicide, and relationship. These are some of the important challenges that I feel make the person so that he can apply the knowledge and wisdom that he has gained from books, teachers, patients, and throughout the professional career. Where psychiatrists have to rethink is their ability to make a difference to others in larger context. Can you just check it? What is the doesn't work? This. Yeah. Before I go there, I want to spend few minutes about World Mental Health Day theme, because I want to take this opportunity to share my thoughts. I feel this year's theme, which says that mental health is a universal human right, is a landmark theme that we have got after many years. Perhaps people are looking at only one side of it, that is right for having services, for having more hospitals, more drugs, more benefits, more facilities, but I don't look at it in this fashion. There are subtle undercuttings to it. What it says that mental health is a universal human right, and we all know that Constitution provides right to life, and Constitution defines right to life is right to dignified life. When the term dignity comes into picture, the whole mental health perspective changes. And if I read 3 sentences that I have written here, anything that is detrimental to mental health is a universal human right violation, or any human right violation is injurious or is a risk to mental health. Alternatively, any action, inaction, event, or legislation that happens to be a risk factor for mental health will also be violative of my human right. So now it has defined that for my human right or for my mental health, you are responsible, and for your mental health and human right, I am responsible. When we say rights, we refer to somebody else. When we say responsibility, we refer to ourselves. The fact that the term right brings in either state or governments or whatever the local bodies that govern, the governance comes into picture. It gives a new definition. It describes a new bond that somebody who is responsible to keep society free from different factors, different forces which determine mental health, need to be cautious that they have to not only manage the mental health but also think in terms of human right. So there are 4 things that come into play. One is self and others, the social conditions and the governments. The 3 together would constitute some aspect of mental health. So psychosocial risk factors for mental health care are also the factors for human right violation. For example, trauma, war, abuse, domestic violence, migration, economic improvements, loans, mortgages, implications for climate change, overcrowding, rapid urbanization or senseless industrialization. So now if there is air pollution on the road or there is climatic issue, it's not only an issue of pollution or civic life. It being a risk factor for mental health, it is also a risk factor, is the factor of human right violation. This definition of defining a bond between cause and consequence in terms of human right is a new phenomena which is happening. You will find after a few years Supreme Court lawyers and others may be discussing this in a different direction. So coming back to our own topic, objective is to find better ways of living and practicing psychiatry. And there are 4 players: the patient, the doctor, the evidence, and the dialogue. All we want to be aware We want to be empowered for challenge in times to come. We want to understand what is the change and what is the challenge. What are the risk factors which put our life, our profession, our income, our credibility at risk? How to empower yourself? What kind of empowerment will be preventive? Professional, academic, legal, social? What will protect life of a psychiatrist? And what is the way forward? Is it cultural or spiritual? So let's say, what is the challenge? My thoughts are that Indian society, which is diverse and resilient, is fundamental to our practice. You do not have that in any country. And if the warmth of this fabric is gradually going down, it's matter of concern and disappointment. But the day Indian society will change and will become structured, legal, construed, solid, commercialized, no dynamics between two people, dialogue becoming difficult, things will change automatically, and we would not know what to do, as we see in many other areas in our society. And the biggest change which is likely to come is socio-demographic condition. We have young people as resource of this country, but down 20 years it is not going to be so. You have to prepare for the generation next, thinking what will be the patient population then, what will be the patient structure then, what will be the therapeutic setting, will there be hospitals, will corporates continue to build more mental hospitals or psychiatric institutions, or will they tell you to manage patients in the house? Will they provide you? Who will govern? That's the crisis. Who will govern? The person who will pay, the patient, the patient's advocate, the relatives, or the corporates or insurance companies, or the government. At what stage you will decide what to do, what not to do, and how to do, how not to do. So there are a number of non-clinical issues which will intrude into our practice and will demand more education, more challenging situation to cope. So if we see the changing scenario quickly, there will be difference in dialogue. Maybe it is unsatisfactory, incomplete, full of suspiciousness, maybe mental health variables, a lot of technology. You need to explain the therapeutics in a different way. The interpersonal conflicts will be many fold. The doctors will also be different. Most of them would be in a rush, more qualified, more specific, more specialist, more medicalized, more in competition, with longer training, years spent in career, financially unsure, with burden of loans and mortgages, and probably disturbed family and single life. As I said, governance is going to be a challenge. There will be issue about role models, because a lot of senior psychiatrists are retiring much earlier in the career. So after 10 years, if somebody retires at 60, the role models will be very, very poor. The mentors will not be available. That is also one of the issues that we need to think about. We all have seen the challenges of evolution of psychiatry in India. We know that demographic changes are going to demand stigma, etc. is going to be an issue. But I'm coming to a more fundamental issue. We will have to define, like the Western countries have done, who is a psychiatrist? What are the characteristics of, what are the basic minimum characteristics of a psychiatrist? Well, I hope I'm correct. And one is bound to conform to the multiple roles of being a professional scholar, a clinician, an administrator, a communicator, a health leader, a researcher, and a patient rights advocate. So our education will have to change in a manner that we are mindful that it is not going to be business as usual. Okay, we'll see the patient, write a prescription and say thank you, go and call me again. It's not expected from us anymore. Probably there will be patients, relatives and other bodies would be more controlling, more regulating our life, and will have to live up to their expectations or rules or regulations. So the challenge will be the challenge of change and transformation, which will be in the field of economics, technology, media and governance. But moreover, we will have to reflect upon ourselves, because we will be responding to a situation, and when we respond, we are human beings. So what do I mean by human being? We are human being by definition. We have a self or personal life. People have issues around relationship. They have a particular type of training and educational background. They do a definite professional work and earn a definite amount of income, and they have a social consciousness. So that is our self, that is our definition of who we are. Based upon our internal resources, we will have to develop methodologies so that we can respond to changes in economy, whether it is expenditure on treatment or it is loss of productivity due to illness, or it is loss of income in our own career. So the transformations are likely to be very interesting. As I said, there will be more geriatric patients. There will be the mean age of first consult will decline. More pediatric psychiatric patients will be having first episode issues. Technology is going to change our life, and it is already changed, and I don't know how much it will change. Nobody is able to tell us. But artificial intelligence, machine learning, digitalization, these three instruments, these three governance have changed not only the content but the quantum also. Now nobody thinks whether the document is 10 pages or 100 pages, because it's automated. It is not that our good old time the typist is typing, so that person is worried about 5 page or 10 page or 10 pages. Similarly, the time constant has changed. So these issues, I am not very sure how these challenges will confront a psychiatrist, but there will be significant change in our lives. Similarly, the cultural transition, that is patient's autonomy of choosing a doctor. Let me tell you, this is such a fantastic asset Indian society has. Can you imagine any country where you can say, I will choose my doctor. I will go wherever I want. I live in Himachal Pradesh and I will go to Mumbai. And I have been going in Lucknow and I have 3 suitcases of record. But I want somebody to review all that and I am going to Kolkata. And you do that all the time. But this is, whatever you want to call it, this is what is available to people of our country. It's not going to be business as usual. It is better to learn to live with the change. Somebody will control the payment. We will have to do what the payment company will tell us to do. We will have to reform the practice. Patients will lose autonomy. It is not going to be possible that morning you will see me, afternoon you see somebody else, and night you see somebody else, until somebody tells you, no, you are not having any psychiatric problem, you just have a personality issue, go home. That's not going to be the mental health practice. Who will decide the reference? and who will pay is a matter of today. A patient can come without a reference. I mean, look at the fantastic system that we have, the greatness of society. Anybody can walk in, and we welcome walk-in people, direct, no stigma. Come, pick up the phone, call up Dr. Bhavi, anybody. Go to his clinic, meet. Patient can be brought by relative. And any relative coming with a patient, we believe, please pay attention to my words, we believe that that person is a legal decision maker, is a substitute decision maker. That is also going to change. Every relative escorting a patient is neither the caretaker nor a decision maker. So the definition of human right, people's right affecting patient care, people's right affecting professional practice, this all is going to be challenged. Super specialists in psychiatry will require infrastructure, human resource aligned with the payment. You will have to demonstrate that you practice geriatric psychiatry. You can't say I just pass opinion and I'm a geriatric psychiatrist. I can't say that I do early intervention setting with the same tools. We will have to substantiate, develop infrastructure, invest money, whether I do or my friends do, my family do, anybody. The evidence will have to emerge that we are different and we deliver. Otherwise, the specialty is not likely to grow. Media is controlling. You do any communication, so the media is changing the narrative of depression. Somebody told me, depression is an in thing. I don't know what is in thing actually. It's a new information for me. In thing. So no, it is a fashionable dialogue. I said, come on. Is it a fashionable dialogue? I said, depression is a disability. So many people have it. I said, no. It is a newspapers have picked it up and they are writing. So newspapers are making narratives. There is already a narrative said that psychiatrists are doctors of sick people. We will have to change the narrative if we want to serve the society. The narrative that psychiatrists are doctors of sick people, this narrative will have to be changed. There will be new educational content like health psychology, shared care, so many other courses. And the power of healing of a doctor will have to be contented. I don't want to cite personal examples here because if, as I said on the first line, if by tomorrow we mean Indian psychiatry going the Western way, then one has a lot to ponder about. A relationship is going to be the key issue, relationship and conflict. I am not talking about only romantic relationship. It is going to be relationship within families, the father-son conflict, wife-husband conflict, doctor-patient conflict, doctor-doctor conflict, multidisciplinary team, your dialogue with the psychologist, with social worker, with physician, so on and so forth. People who pay for your research, people who pay for your education, people who pay your fees. With all of them, you have a relationship. You are surviving because you have a healthy relationship. Your life is likely to be difficult if that relationship is strained. And chances are that probably we'll have to learn how to manage relationship much more smoothly. This is the time to have newer courses for ourselves to learn how to manage. Now, in terms of the subject of mental health, there is a reverse dichotomy, the reverse paradigm. As I said, we are doctors. We were trained to treat ill people, people who are suffering, people who are sick. The entire MBBS curriculum is loaded with illness. But what is the condition now? Just see. One philosophy is, what has gone wrong, we fix it. So if somebody has cancer, you try to fix it. But the other thought is, what can be done to restore what has not developed or what has lost? So we were the doctors to treat an illness. Now the question comes, should you treat illness or you can treat symptoms? When somebody tells, find out early intervention, so if anybody has only delusional ideas and not fitting into psychosis definition, will you treat that person or not? At least you will monitor that person or entertain that person? Yes, of course. Then it came to find out whether somebody is vulnerable or likely to develop a mental disorder, or please tell me if the time.
Yeah, so 3 minutes more.
Okay. Or then we are told, okay, no, find out if somebody has risk of developing a psychopathology. So manage the risk. Then we are told, no, not you are custodians of wellness. So wellness, how happy you are, how contented you are, how much money you make, how is your relationship, all that thing is into my therapeutic paradigm. So look at in last 20 years, if the thinking has changed this much, I do not know in the next generation where does it go. So let me conclude. For the practice, I conclude, for a productive practice, we must define our own rules, our do's and our don'ts. Social and emotional consciousness is not legal, we must remember. And if we continue to dominate our emotional consciousness over social consciousness, there might be consequences. Practice license is a legal document which does not recognize diversity of village or poor place or a poor person. It's going to be uniformity. So we must make our own rules and we should not break our own rules. Draw your boundaries, respect your rules. Rational pharmacopoeia is one of the thought. Every word that a doctor speaks, good or bad, is a therapy. We must remember that. Early intervention versus treatment of a symptom. And leave no gaps. Do what best you can, but do only what you can do. If we remain in conflict and confusion and try to cross the boundary that we will do X, Y, Z to entire cafeteria of mental health practice, probably we will be misleading ourselves and inviting trouble. Well, there is a lot to talk and we can always discuss in free time. Thank you very much for this patient hearing, and I much appreciate the Committee of Indian Psychiatric Society Western Zone branch to give me this opportunity. Thank you.